How often do you re-bronch? I have to say, and you guys are going to agree with me, sometimes you are just even lucky if you just get one bronchoscopy done. So asking for re-bronchs is a very, very difficult task. And I have, again, in some of the questions that they ask here, this some of the institutions that, again, and this happens more and more often in the institutions that don't have too many donors. And that's why I think that is the role of creating these kind of centers for organ donation or these donor hospitals where the patients can be transferred when these things become like everybody understand what we are doing. But even here, working with the OPO here in Living, New York, that I have been for a while, and also with CDT now, is they call me and say, oh, we are not having a bronchoscopy. It's a donor that we start working on Saturday and say, we don't have anybody to do it until Monday. So I'm very realistic about the option that re-bronching is very, very difficult to do. However, you ask me, under the ideal circumstances, when patients come to our center, that is, again, a donor management center, how is the process of bronchoscopy under the ideal circumstances? When the donors get here, very quickly, again, is the formal assessment of the donor. A lot of the very time-consuming paperwork that needs to be done by the coordinators is done in the original institution where they are coming. So at least we save all of that time, and the donor is coming here for true donor management. And when they get here, we almost immediately start doing the donor recruitment. We have an X-ray obtained immediately. We have a blood gas, and then we do a bronchoscopy within the first couple of hours that they get here. And that kind of give us a little bit more of an idea. Are we dealing, again, what problems are we dealing? Do we have a lot of secretions? Do we have evidence of aspiration, a lot of mucus plugging? And once we have that bronchoscopy, the decision to do the next bronchoscopy depends on how things are going. If the donor continues to have issues, and we have a lot of problems with secretions, or we have a lot of mucus plugging, and we repeat the X-rays again 8 to 12 hours later, the recruitment is not working quite well, and we just want to say maybe that this is not going to work, but we just want to be sure that the airways are better and we can do our recruitment and things better. We try to repeat the bronchoscopy, or especially they are kind of getting close to go to the operating room. We like to have a bronchoscopy for them to be sure that there is not going to be issue by the transplant center when they get there, and in that refusing a lung because they see some mucus plug or something when they get into the OR. I will say that the answer to this will be according to clinical indications. You ask me how many bronchs we do in average in the donors, we probably do 2, one at arrival and one probably 12 to 24 hours later. By then, again, we are going to just determine where we are. And that's actually another thing going around in this question is, if you implement a very well-structured and organized donor management plan, when you say, this is the problem, we already bronch the patient, we have the X-rays, we have the blood gas, we have a recruitment protocol, we are diuresing the patient, you do that for 8 to 12 hours, then you have a little bit of improvement, you say, okay, we can go another, again, 8 hours, and after that, we are done. But you do all of those things, and the next morning, the X-rays is completely, again, PS type of X-ray, the PaO2, the PFR is still 180, you can start moving on that donor and say, you know, this is not going to work. Again, we have been doing this. We understand what the problem, and we give a diagnosis and say this patient has a multi-lobar pneumonia, very hypoxemic, non-compliant, no recruitment, lungs didn't get better. Remember how I start saying, we are trying to prove that these are good lungs. We are not trying to make bad lungs less bad to give less bad lungs to a recipient. That's not what the transplant centers will take. And that's not the goal of the OPOs trying to sneak some kind of bad lungs, let's kind of make these lungs look good. And in that way, when we make them look good, even if they are not that good, we may have a chance to place those organs. That's not the business that anybody is. It's not what the OPOs and us, when we are taking care of donors, we are trying to do. We are trying to do is prove that these lungs at the end look good. They didn't look good because they were fluid overload, because they were atelectatic, ventilated with an ARDS mode of ventilation, full of, again, atelectasis and problems that they have. And we say, let's recruit it, let's fill these lungs with air, let's do the proper ventilator management, do our bronchoscopies, clear the secretions. And honestly, in most of these donors, between 8 to 12 hours later, you will get to your response. Yes, we make these lungs better, we can start moving towards donation, or we won't be able to do it.